Good evening, everybody, and welcome to the second webinar in Rural Health West's Medicare series. Tonight we'll be presenting on chronic disease management and mental health care plans. We are delighted to have Donna as our presenter again for this evening. We have a fair bit to get through, so I'm going to pass over the reins straight away to her. But as a reminder, please remember to use your chat box. So if you've got any questions throughout the evening, I'll be keeping an eye on those. So over to you, Donna.
Hi everyone, thank you so much for joining us again. I did this last week, so if you haven't had a chance to listen to last week's, I'm sure you can get in contact with Beth, and get a copy of that. But also super glad to be here tonight on chronic disease management and mental health care plans. Chronic disease management is certainly one of my favourite topics, believe it or not. Just love it and love what it can do for the patients and for organisations. So without further ado, we'll soldier on. So my name is Donna. I'm a registered nurse is my background. I started working in general practice in 2009 and in 2011 started a consulting company that works with general practice, Aboriginal medical services and alike around chronic disease management, health promotion, and more importantly, putting a business model around those things in a general practice setting and in a way that engages the GPs, the nurses, the receptionists, and most importantly, the patient, and makes all that work really well. I do a lot of work with Flinders University on some research projects around chronic disease management and improving health outcomes. Do a lot of work with the Royal Australian College of GPs. Great organisation to be working with and really setting some standards in care delivery for general practice in Australia. So I've got a diploma of management. I do lots of training and assessment and also did a graduate certificate in chronic disease self-management and also a member of the Australian Institute of Company Directors. So fingers crossed, the outcomes of tonight is just to develop an improved understanding of some MBS items, to discover how to adopt a business model to support chronic disease management and mental health care plans within an organisation, and to discuss collaborative care where the nurses fit into care delivery in that primary healthcare space. So a couple of little icons will pop up on these screens as we go along. So because we're talking around Medicare, chronic disease management, it's really important to do what Medicare says. So when you see this little symbol come up that says compliance, rules, regulations, and guidelines, that is information that has pretty much been cut and paste from either mbsonline.gov.au or humanservices.com.au. So it's just really a cut and paste of what Medicare is saying. So it's something that I haven't taken and then put into my own words. It's what Medicare says, which is really important in those situations. And if you see a little yellow post-it note, that's a tip. Working in general practice since 2011 across the country, I've worked in practices with one GP, the wife is the practice receptionist, to practices that have 25 GPs and a full swag of allied healthcare providers. So you learn a lot over those things and you pick up some tips and tricks along the way that I'm happy to share with you tonight. And if this little bubble comes up with frequently asked questions, that'll mean that that particular topic that we're on will get lots and lots of questions around that. So it's something that you've probably thought about or have thought about asking. So hopefully that'll come up tonight as a frequently asked question. But as Beth was saying, please feel free to send through any questions through the chat box. I'll be keeping an eye out, and Beth certainly will. And if I don't see it pop up, Beth will jump in and remind me that there's a question there, and we're happy to answer them. So happy to answer them as we go through or at the end or whatever works, but feel free to send them through. So we'll make a start. Lots of information to get through tonight. So a background, and this is information that we know. This isn't a surprise, but Australia has one of the highest life expectancies in the world, and the majority of people consider themselves to be in good health. However, not all of us are as healthy as we could be. And I think the latest statistics are 50% of the Australian population say on a self-reporting basis that they have at least one chronic condition. So chronic disease management certainly isn't going anywhere. It's not a series of events that we're managing to manage and get a hold of, and there's a bright future. Chronic disease management is huge. It's a big problem in Australia. 50% of your patient population, self-diagnosing at least one chronic condition for themselves. So the Department of Health, in July the 1st, 2005, the Commonwealth Government introduced programs such as the GP Management Plan, or what we can call a GPMP or a care plan. They also introduced Team Care Arrangement, which is that we often just call a TCA, and Practice Incentive Payments, or a PIP payment. Just a little thing, EPC, we often use that term, Enhanced Primary Care, or the EPC form. That's a language that went by the wayside quite a while ago, so it's not even a term that we really refer to anymore, but it still gets used every now and then. But the terms at the government department now are a GPMP or a TCA, and of course your PIP payments. And mental health care items provide a structured framework for GPs to undertake early intervention, assessment and management of patients with mental disorders, as well as providing referral pathways to clinical psychologists, registered psychologists, and appropriately trained social workers and occupational therapists. So the Department of Health is recognising that health promotion should always be a goal. We want to prevent chronic disease and mental health. But, in the event that we have chronic disease and mental health, what are some of the pathways and the item numbers that we can actually navigate through to manage these patient populations? So interestingly, we showed some stats last week around the uptake. So between July 2017 and May 2018, which is the latest figures that I can get, was over 10 million general attendance consults in Western Australia. They're the breakdown of item numbers for GP management plans, for reviews, and for mental health care plans. So you can see with those numbers of all the attendance that are happening in Western Australia, 2.17% is for a care plan. 3.22% is for a review of the care plan. Now, interesting here to note that 732 of 3.2%, you could probably halve that, because in most instances, that number will be billed twice on the same day. So we're not doing great for reviews, and we're certainly not overbilling care plans. And mental health care plans and associated only 2.5%. So we often, talking to GPs, I often say, these are not items that we're doing too many of. We're overdoing it. There's going to be a red flag. We're going to be audited. We're doing way too much of these things. When the reality is, it's 2% of a general attendance consults in Western Australia in the last 12 months. So something worth considering. We mentioned this last week, and I don't think we can, mention this enough. And for the general practitioners that are listening in, or as a practice manager, or even as a practice nurse, really important to understand that under the Health Insurance Act of 1973, you're legally responsible for services billed to Medicare under your Medicare provider number or in your name. So certainly applies to general practitioners, but also nurse practitioners and Aboriginal and Torres Strait Islander health practitioners, that the item numbers that you bill, you are responsible for. Often here GPs will say, I leave it up to reception to bill my item numbers for me. I wouldn't have a clue about item numbers. A little bit foolish, if I can be so bold as to say, because ultimately you are legally responsible for the item numbers that you bill under your provider number. So there's a real responsibility to understand those item numbers and to understand what you're billing. So tonight we're going to help you navigate through some of those chronic disease management and mental health. And if you didn't hear last week, maybe get a copy of those notes, because that helped us navigate through those health assessment item numbers as well, just so you can be sure that you're billing appropriately. So we'll crack on to chronic disease management, which of course is my favourite topic. I have got my my countdown here, so I won't ramble on too much, but easy to get carried away with chronic disease management. So rules and regulations. So you'll see at the top, there's compliance rules, regulations, and the guidelines, little image, and frequently asked questions. And like we alluded to last week, it often comes up, well, who is the patient's GP? Who is the patient's usual GP? And so this is cut and paste from Medicare. For the purposes of health assessment items and also chronic disease management, the usual doctor means the general practitioner or general practitioner working in a medical practice, which has provided the majority of primary care to the patient. So often we say, oh, it's my patient, but I haven't even seen them for 3 months. But they may have been a patient of that practice for 2 years. It's where does that patient identify as their practice home? And if that practice home is a practice and they see, the female GP for some female GP bits and pieces and the male GP for this, and they might see someone else for that, they are a part of that practice, and anyone within that practice then can provide that patient with health assessment, chronic disease management, and mental health. So I hope that clears that up. It doesn't have to be the one GP, it can be within the practice. And often that gets changed around how the practice runs as a clinic and as an organisation. Some practices like it that patients don't have a particular GP, but they're a patient of the practice. So it just depends where you're working. To be eligible for any CDM items, the patient must have a chronic or terminal medical condition. So this is one that has been likely to be present for 6 months or longer and includes, but is not limited to, asthma, cancer, cardiovascular illness, diabetes, musculoskeletal conditions, and stroke. I hear this often, which is why the frequently asked question is there, is, well, what is a chronic condition? And you'll hear, oh, it's got to last longer than 6 months. We kind of stop at that. Or it's going to be diabetes and heart disease, and we stop at that. Certainly that's what Medicare says in this instance, but there's so much more to that answer. So the Medicare Benefit Schedule, or MBS, does not list all possible medical conditions that are or are not regarded as chronic medical conditions for the purposes of CDM items. And interestingly, it never talks about a chronic disease on MBS. It's a chronic condition, a chronic medical condition. So whether a patient is eligible for a chronic disease management or CDM service or services is essentially a matter for the GP to determine using their clinical judgment and taking into account both the eligibility criteria and the general guidance. So I can't stress this enough, that it is a GP's clinical decision of what is or is not a chronic condition for that patient. So we'll keep going. So where a patient's condition would not obviously come within the MBS definition, which is, like we said, diabetes, heart disease, osteoporosis, the musculoskeletal, cardiovascular, a GP may still consider the patient's condition and circumstances are such that they require the preparation of a care plan because of such factors as non-compliance, an inability to self-manage, or functional disability. We'll keep going. The department has received queries about whether the following are chronic medical conditions, such as alcohol and other substance abuse, smoking, obesity, unspecified chronic pain, hypertension, high cholesterol, or syndrome X, or metabolic syndrome, impaired fasting glucose tolerance, or impaired glucose tolerance in pregnancy. Remembering this is cut and paste from mbsonline.gov.au. So in these cases, this would not normally or commonly be regarded as a chronic medical condition in themselves. Some may be more accurately be regarded as risk factors for developing a chronic condition. Some possibly relate more to personal choice or behaviour issues, and some, like pregnancy, could be regarded as a normal part of life. The department recognises, however, that conditions such as these can occur across a wide spectrum of severity and in a broad range of circumstances with, for example, some patients with one or more of those factors being unable to self-manage or comply with care and treatment, being functionally disabled by their condition. In many cases, a patient may have complications or comorbidities that may be a result of or exacerbated by such conditions or risk factors that would make them ineligible for CDM services. So hold on, there's an end to this. Stick with me. In these cases, the GP should satisfy themselves that their peers would regard the provision of a CDM service as appropriate for that patient, given the patient's needs and circumstances. So what we're saying during all of that is, yes, your diabetes, your heart disease, your musculoskeletal, your typical, if I can call it that, your typical chronic condition. So if you have a patient then that comes in with, we'll take their obesity for an example. And a lot of practice in the past has said, I can't put a patient with obesity on a care plan because it's not a chronic condition. What Medicare is saying there is that it's up to the GP's clinical decision as to whether or not that patient should have a care plan, taking into account the patient's ability to self-manage. So if you had a patient who was obese in itself, left to their own devices and unmanaged, you could argue that it's going to lead to potentially diabetes, heart disease, and a whole bunch of health concerns. If you, as a GP, were to think, if I put this patient on a care plan, I can get them to a dietitian, I can get them to an exercise physiologist, I can monitor their weight loss regularly, I can do regular bloods, blood pressure, high cholesterol readings, blood sugars, I can do these things regularly. If you sit there and you lay out your case, and even if you talk to a peer and said, this is what I want to do with this patient, and a peer would say, that makes sense to me, then you can put that patient on a care plan. That gives it a tick. It's a yes. Now, if we extend that out further and say, well, what happens then if we have a patient with hypertension? A lot of practices will say, we're not putting our patients with hypertension on the care plan. And I'm quite conservative when it comes to Medicare. I'll often, we'll be quite conservative on what we do and don't with clinics. So I'm certainly not saying leave here tonight and tomorrow put all your patients with hypertension on the care plan. But what I am saying is if you've got that one hypertensive patient who is on medications for his hypertension, but there's a medication compliance concerns, he's not taking his medications, his BMI is increasing, his food choices are bad. He's a smoker on top of his hypertension. There's a family history of, cardiovascular disease. If you were to say to that patient, we want to put you onto a care plan where we can monitor this closely, where we can, go through your medications with you, where we can send you off for exercise physiology, get you in touch with the pharmacist, whatever it may be, if you can justify to yourself and a peer would agree that service provision is in the best interest of the patient and it stacks up, then it's a GP's clinical decision to do that. So that is fine. I always say to GPs, imagine if you've got someone from Medicare sitting across the desk from you and you want to tell them the story. And if they say to you, why did that patient go onto a care plan? Can you tell them the story about that patient? Can you say, well, this is why I did it and this person agreed with me? If you can do that to that Medicare officer across the desk from you, then go ahead, please, and provide that care for that patient. And I know there's probably GPs there going, oh, I don't know, I've spoke to such and such, and my neighbour's best friend's neighbour's dog's owner, whatever, saw them at a party and he said, no, you can't do that. What we're saying here is this is what Medicare says. Medicare doesn't say that you cannot do a care plan for a patient on hypertension. It's saying it recognises that there's different risk factors, there's compliance issues, there's a whole bunch going on with this patient. What is in that patient's best interest? So really important to get your head around that. And I know that can be quite controversial for GPs, practice owners, nurses to get their head around that. But just go back to Medicare. What does Medicare say, and what's in the best interest of the patient before me? How am I going to get that improved patient outcome? So getting some rules and regulations around the GP management plan, which is an MBS item number 721. So these are available to patients in the community and private inpatients of a hospital, including private inpatients who are residents of aged care facilities being discharged from hospital. They are not available to public inpatients of a hospital or care recipients in a residential aged care facility. So the rule of thumb here is that GP management plan are to your patients living in the community. It just keeps it simple. more rules and regulations. A GP management plan. A comprehensive written plan must be prepared describing the patient's healthcare needs, health problems, and their relevant conditions. Remember, it's not saying their relevant disease state, but their conditions. Their management goals with which the patient agrees, actions to be taken by the patient, treatment and services the patient is likely to need, arrangements for providing this treatment and these services, and arrangements to review the plan by a date specified on the care plan. So when you're doing a care plan, Medicare wants to know these things. And again, if that Medicare officer was sitting across the desk from you, can you produce a document or produce your medical progress notes for a care plan for that patient that outlines those things? That's what they want to know. In preparing the plan, the provider, which is the GP, must explain to the patient and the patient's carer, if that's applicable, the steps involved in preparing the plan. And they must record the plan and record the patient's agreement to the preparation of the plan and offer a copy of the plan to the patient and add a copy of the plan to the patient's medical record. Really important note here that they don't need to take a copy of their care plan. They just simply need to be offered a copy. And you need to document that the patient's aware of the process that they're going through. So many times you hear, patient came in and they didn't even know they had a care plan. Sometimes they get caught up in all the, the medical mumbo jumbo, but often we just don't sit down and explain the process. But we need to explain the process and they need to agree to the process. So here's a tip, and we spoke about this last week as well. So most electronic health records, so that's your best practice, your medical director, your communique, your genies, those kinds of things will have some functionality to create a shortcut or an autofill. So you can try creating a shortcut that simply says, patient attended today for a GPMP plus or minus a team care arrangement, explanation provided about the process and benefits, patient has given verbal consent for the care plan or the team care arrangement. And you can document that in your progress notes. So it's there, it's written in, and you can have an autofill, then you might be able to add in, bits and pieces to that, or add in their name or whatever. But it's just reminded to make sure you document that the patient is aware of what's happening and they've given consent. And what you can also do is that you can edit or modify any of your existing care plan templates. So again, you can simply add a box or add this sentence at the beginning of the care plan or at the end of the care plan, the same wording that the patient attended, they're aware of the process and consent, verbal consent was given. So you're just documenting that consent was given. It doesn't need to be signed consent. Often what I see happening is that they'll print out the care plan, they'll get the patient to sign it, and they'll scan it back in. That's not required. I've never seen in Medicare where it says need to be assigned from the patient for consent. They just need to provide consent, and that can certainly be done verbally. But again, you just need to document it, and that's quite an easy thing to do. So then we have our team care arrangement. I've got to be careful here because team care arrangement, that discussion can go on for a very long time as well. It can get very complicated. So tonight's just an overview of this, but you can certainly get more information from MBS online.gov.au. So when coordinating the development of a team care arrangement, the general practitioner must, so again, this is cut and paste, must consult with at least 2 collaborating providers, each of whom will provide a different kind of treatment or service to the patient. Now, we all know this, it's a GP and 2 others. Easy so far. Preparation of the document that describes the treatment and the services, goals for that patient, treatment and services that the collaborating providers will provide to the patient, actions to be taken by the patient. So what is the patient going to do? What are they contributing to this? And arrangements to review the team care arrangement by a date specified in the document. Medicare wants to know that you're setting up a care plan, that you're setting up a team care arrangement, and the patient's going to come back and you're going to review it. Is this working? Is this not working? Is this actually achieving what we're setting out to achieve? So when are they coming back? So the team care arrangement need to explain the steps involved in the development of the care plan and the team care arrangement to the carer, and discuss with the patient the collaborating providers who will contribute to the development of the care plan. So that's really important too. Now, I'll keep it really short here, but really important to remember that a team care arrangement, the whole idea of this is collaborative care. And we talk about patient-centered care a lot, but as clinicians, we don't often do patient-centered care very well because it's messy and it takes a long time. And sometimes the patient's goals and expectations are different to our goals and expectations for that patient. I'll tell a quick story. I had a patient come in when I was doing care plans, newly diagnosed diabetic lady with a BMI of 56.1. And so, of course, she's come in and I've done her care plan. We've spoken a little bit about nutrition, exercise, diabetes, the importance of foot care, and a whole bunch of stuff for her. Didn't want to, overload her because, it was still quite frightening to be newly diagnosed with diabetes. So I finished my care plan and I said to her, if there was one thing that I could do for you today that would help you, just one thing, what would it be? And inside, I'm thinking, please say diet and exercise. Please say diet and exercise. And she turned around and said, my feet hurt. My feet hurt. That's all it is. That's the only thing that matters to me at the moment. So I said, absolutely, I can see how that would be awful that your feet hurt. So I set her up for some podiatry care. And I think we sent her off for exercise physiology as well because it met my GP plus my two others. And off she went. She came back in 4 months' time for a review, and I did my care plan again. And I said to her, if there was one thing that I could do for you today that would be helpful for you, what would it be? And she goes, oh, I need to lose weight. And inside, I'm like, yay, we've got there. This is fantastic. On the outside, sure, I can see how that could be really important to you. So let's look at some of those ways that we can, look at diet and exercise, and maybe send you off for, a dietitian, and we can set some goals and we can work with you on that. If I had have said to her at the very beginning appointment, you need to lose weight, you need to see a diabetes educator, dietitian, exercise physiologist, I may have lost her, I might have lost her confidence in me, I may have lost her buy-in to a care plan because it wasn't her goal. Her goal, or at that point in time, was my feet hurt, I just want you to fix my feet. So patient-centered care, it's messy and it takes a while because we've got to work with the patient on their journey. But if we can do that, we always get an improved health outcome because you build that rapport with the patient when they become on your side. So that's where team care arrangement, it's not about where we think they should go. It's in collaboration with them, what's important right now and what can we set up together and what can we work towards. So just really important about team care arrangements there. So team care arrangements need to record in the patient's notes that they agree to the development, need to give copies of the relevant parts of the document to the collaborating providers, offer a copy to the patient who is quite okay to say no, and add a copy of the document to the patient's records. So again, very similar to your GP management plan, but also your health assessments. Now, it's, has the patient agreed? Are they aware of what's going on? And can I document that this encounter actually happened? Now, provided the two services are delivered as per the Medicare requirements outlined, they can be claimed on the same day. But in many cases, billing a 721 and a 723 on the same day would be unlikely, given that team care arrangements involve collaboration with the participating providers to discuss the following: the potential treatments and services, documentation of the goals, the collaborating providers, and patient's actions and review date. What this is saying is, and typically what happens is a patient will come in, we'll do a GP management plan, we'll do a team care arrangement, we'll fax off to the podiatrist or to the physio will you participate in this patient's care as an allied healthcare provider. We fax it off, patient goes out to the front desk and we bill a 721 and we bill a 723. What Medicare is saying is, in order to bill a 723, you need to have already collaborated with your allied healthcare provider. They need to have discussed with you what treatment or services they're going to provide for that patient. How are they going to see that patient? What are they going to do for that patient? And then when we've had that discussion, at that point, can we bill a 723? It's all very confusing, I know, but that's what Medicare says. So what is meant by collaboration? So collaboration means communicating with the other providers to discuss potential treatment or services they will provide. So, Mr. Podiatrist, I want you to see Donna. She's newly diagnosed diabetic, and I want to do a comprehensive foot check, give her some education and training around foot care, some diabetic foot care, so that she can continue that on and maybe review her every 6 months. So, and then the podiatrist will go, thank you for that referral. Yes, I will see Donna and I will provide a comprehensive foot check. And in that foot check, I will check her pedal pulses. I will show her about making sure that she does a foot check and her feet are moisturized and all those kinds of things. So that's two-way communication. So communication must be two-way, preferably oral, it says in Medicare, or if not practical, then in writing. It should relate to the specific needs and circumstances of the patient, and the communication from the collaborating providers must include advice and treatment and management of the patient. So what happens is we get that, will you participate in this patient's care? And we fax it off. The provider just simply signs the bottom of that same sheet of paper and faxes it back. And we put that down as we've had collaboration with our allied healthcare provider. But in actual fact, they haven't collaborated on anything. All they've said is, I will see that patient. But they haven't discussed what they'll actually do with that patient at all. And interestingly, it says it prefers oral, but if you can't do oral, then you can do faxing and all sorts of things. So just on that, what's really important, and I hear all the time of, that's ridiculous. I can't, sometimes it takes weeks to get those faxes back and I can't not bill for weeks. Jump on the phone. Like if you've got a receptionist or nurses or medical assistants, whatever it may be in the clinic, jump on the phone, ring up the allied healthcare provider. I'm sending such and such to you. This is what the problems are. This is what we think she needs. Will you be able to see her and what will you be doing? I'll be doing this. Fantastic. Thank you. Hang up. Document that in the patient's record that you've had two-way communication. You spoke to that person on that day. That fits Medicare's requirement. Job done. Bill it. Does that make sense? We get so hung up on how difficult it is when it's not actually that difficult. Just communicate with them. It may be that they only work on a Tuesday. Ring them and say, would it be okay if on a Tuesday morning we just took 5 minutes of your time, almost like a case study, went through the referrals that we're going to send to you and get that communication back and then document it all. It's just really important that that two-way communication happens. So I hope I've cleared that up a little bit for you. So the rules and regulations, a GP management plan, item number 721, the recommended frequency is 2 yearly for a new care plan and minimum claiming period of 12 months. Same again for the team care arrangement. And the review of a GP management plan or a team care arrangement, which is item 732, is 6 monthly, and you can claim after 3 months. Now here, I don't know if I've got it as a tip or trick next. We used to do all our reviews 4 monthly for our diabetic patients and 6 monthly for our other ones. And that was just how, as a clinic, we decided to do it. Part of our strategy around that 4 monthly recall was often you'll hear that, you went to bill an item number and it was rejected because they came in a day early or 2 days early. What happens is if you recall a patient for 4 months, it's very rare that you'd actually send out a reminder for that recall and they'd make the appointment a month early. Or you make the appointment a month, 4 months in advance, they're going to ring up and cancel and come in a month earlier. So what it does is it gives you a couple of week buffer, whereas if the appointments are changed, if your recall letters go out a little bit early, you've got a 4-week buffer before it becomes too soon and your claims get rejected. I hope that makes sense. But of course, there's nothing to preclude you from doing 3 monthly reviews. With our patient with a BMI of 56.1, we did 3 monthly reviews because she just, it was a difficult time for her, going through lots of change, newly diagnosed diabetic. So 3 months really worked. If you wanted her into the clinic, and to see more regularly. But then we might have, an osteoporosis patient who's managing quite well. She attended a falls clinic. she's got a really good oral calcium intake. Things are going quite well for her. So 6 monthly, could work. So it's really patient by patient that you need to do this. A little something extra, conversations matter. We've talked a lot about the rules and regulations around Medicare and what you can and can't do and the documentation. A lot of what we do as an organisation, what I do working with practices is, yes, we understand Medicare and yes, we know what's required from Medicare, but the whole goal or the desired outcome is an improved patient outcome. I don't know of many patients who get an improved patient outcome by this whiz-bang document that the template's written on. What changes a patient's behaviour and improves their outcome is the conversation that you're having with them, like BMI 0.1, BMI 56.1, BMI lady. Like, it wasn't the document, this beautifully crafted template that got her around to, I need to lose weight. It was the conversation. It was the motivational interviewing. It was the buy-in. It was patient-centered care. It was listening. It was, that's what changes a patient. Sure, we've got the care plan item numbers to support that kind of work and to kind of guide how it is. But if I can urge you to do anything around chronic disease management, A, it's certainly no Medicare, but B, like, what is it that your patients need? And are your nurses or the GPs, do they have the skills necessary to do chronic disease management? We often think that it's just a given that anyone can sit down with a patient for 40 minutes and talk about their diabetes. No, but it's quite a skilled area. An example, a question, if I was to say to a patient, how's your diabetes? Usually they're going to reply back, it's good. End. That's the end of that conversation. Or you can say to the patient, tell me about your diabetes. It's a very open-ended question. So they then have to explain, oh, well, my diabetes is this. Explain to me the medications that you are taking, not do you take your medications every day? Because they're going to go, sure. Explain to me the medications that you take. What do they do? What are they for? And it's reframing those questions, and that's where the improved patient outcome. So yes, we need to know Medicare. We need to know Medicare's requirements and the templates, but it's all about the conversation too. You can't gloss over the art of a conversation around chronic disease management. So nurses, this is where nurses, speaking as a nurse myself, are really valuable to that space. So a practice nurse, Aboriginal and Torres Strait Islander health practitioner, Aboriginal health worker can assist the GP with chronic disease management. But again, it's the GP deciding what skills and abilities does that person have in order to enhance the process. So there is a Medicare rebate assistance for nurse contribution, and it's an item number 10997. It can be claimed under Medicare for monitoring or support services provided by a person with a chronic disease. The service is provided on behalf of and under the supervision of a GP. The service must be consistent with the patient's care plan, and they have a maximum of 5 services per year in a calendar year. So they're worth $12 each, but that means that for each patient, that's $60 worth of additional MBS revenue to the clinic to provide work that no doubt the nurse is already doing. Let's just attach the item number to it. Really important here that item number gets attached to the GP's provider. Not need to see the GP in order for that number to be billed, but the nurse needs to see the patient, needs to document something's happened. It needs to be consistent with their care plan. But if all of that's happened, then it can be attached to the GP's provider number. But again, the GP doesn't need to see the patient. So make a plan. Most EHRs will have the functionality to search specific patient cohorts. So try searching for a specific patient population and working through that in a systematic way over a specified time. Like I said earlier, 50% of patients are reporting at least one chronic disease. Even if you're a small practice with 1,000 patients, it means 500 of them potentially have a care plan. Where do you start with 500 patients in a small practice? Maybe you start with the diabetics. You just start there. You know that saying, how do you eat an elephant? One bite at a time. You just chip away and you just start somewhere, but you don't need to start with the whole 500. So using this specific patient cohort, try implementing an individual or small group clinical audit within your practice. I know working with the RECGP, they've got their plan thing about GPs having to do their plan for continuing improvement. There's no reason why you can't make a diabetes, a PDSA, a Plan Do Study Act activity around diabetes, and you can make that your QI activity as a GP, and then make it as part of the clinic. So you can just sort of think about how we can do chronic disease management and actually make it tie in with what you need to be doing anyway. A lot of the thing here, don't give it away. So a lot of services delivered in general practice are not billed, due mainly to uncertainty around eligibility or poor processes. So what you're learning tonight around chronic disease management, share with your colleagues. Sit down and talk about this, and get familiar with Medicare so that when you deliver the service, you're actually billing for it. It doesn't make a lot of sense to do the work and not get paid for it. So mental health treatment plans. So let's talk about mental health. So general practitioners or GPs are often the first port of call for people seeking help with a mental illness. This is where patients are going. They're going to their GP. The GPs are really the gateway for all of healthcare. You can't see a specialist without your GP referral. Your psychologist, you're this, you're that. Like GPs really are, they are the cornerstone of primary healthcare in this country. Since the introduction of the GP mental health care items as part of the Better Access Innovative Initiative in November, there's been a steady growth in the number of Medicare subsidised mental health items, as demonstrated by an increased annual growth of 8.6% in the rate of services over 5 years. So these mental health care plans, they are increasing. Is it because we've got more mental health concerns, or is it because as a society we're getting more comfortable talking about mental health? There's the Are You OK, the Black Dog Institute, where once upon a time we didn't really talk about depression or anxiety or phobias. We just kind of just brushed it under the carpet. So maybe the increase now is that we're more comfortable with having these discussions. I'm not sure. So GP mental health treatment items were introduced on a Medicare Benefit Schedule, and there they are. There's MBS items 2700, 2701, 2715, and 2717, which are the preparation of a mental health treatment plan. There's also MBS item 2712, which is the review of a GP mental health treatment plan. There's also MBS item number 2713, which is a GP mental health treatment consultation. So this is a consultation given to a patient around that mental health, that they don't need to necessarily be on a mental health care plan. We'll go into these details a bit more. So item number 2700 is a mental health care plan. We'll call it that just for sake of time. Is for a GP who has not undertaken mental skills training of at least 20 minutes but less than 40 minutes, and a 2701 who has not undertaken mental health training of at least 40 minutes. So they're the two item numbers. They're time-based, but for GPs who have not undertaken mental health skills training. And you've got these two item numbers, 2715 and 2717, for GPs who have undertaken the mental health skills training. So same time limits there, but these guys have undertaken that training. So I hope that makes sense to you. These items are for patients with a mental disorder who would benefit from a structured approach to the management of their treatment needs. A mental disorder is a term used to describe a range of clinically diagnosable disorders that significantly interfere with an individual's cognitive, emotional, or social abilities. So really important there. We see a lot of mental health care plans done that are a bit vague in their diagnosis. Again, this is cut and paste from Medicare. So you really need to know what is the clinically diagnosable disorder that is significantly interfering with this patient's cognitive, emotional, or social abilities. Dementia, delirium, tobacco use disorder, and mental retardation are not regarded as mental disorders for the purposes of a GP mental health treatment item. Again, straight from mbsonline.gov.au. These GP services available to eligible patients in the community. A GP mental health treatment plan and review services can also be provided to patients in hospitals and patients of residents of aged care being discharged from hospital. Where the GP who provides the GP mental health treatment item is providing inpatient treatment, the item is claimed as an in-hospital service. So you get 75% of the MBS billings. But again, more information on mbsonline.gov.au. A rebate can be claimed once the GP has undertaken an assessment and prepared a GP mental health treatment plan. The item covers both the assessment and the preparation of the GP mental health care plan. Where the patient has a carer, the general practitioner may find it useful to consider having the carer present for the assessment. But again, it's, does the patient consent, and is it actually going to add value to that appointment? An assessment of the patient must include recording the patient's agreement to the GP mental health care plan, taking relevant history, conducting a mental state examination, assessing associated risk and any comorbidity, making a diagnosis and/or formulation, and administering an outcome measurement tool. In preparation of a treatment plan, in addition to assessment of the patient, preparation of a GP management plan must include discussing the assessment with the patient, including their mental health formulation and diagnosis for provisional diagnosis, identifying and discussing referral and treatment options, and agreeing goals with the patient, what should be achieved by the treatment and any actions. So it's not just a mental health care plan, let's whip through this and see to a psychologist. It's, this is a plan. It's you're involved. This is part of the patient's care. It's not a referral process, but you're actually part of this patient's care. Provision of education, a plan for crisis intervention and for relapse, making arrangements for required referrals, and documenting. Again, document. If you're billing something, have you got the documentation to support the billing? So once a GP mental health care plan has been completed and claimed on Medicare, either through item numbers 2700 through to 2717, a patient is eligible to be referred for up to 10 Medicare rebatable allied mental health services per calendar year for psychological therapy or focused psychological strategy services. Patients will also be eligible to claim up to 10 separate services for the provision of group therapy. So again, this is, in consultation with you and the psychologist around what's in the best interest of that patient, what service is going to be required. Is group service going to be a really good add-on to that? So again, this is in collaboration with the mental health care team. Many patients will not require a new plan after their initial plan has been prepared. A new plan should not be prepared unless clinically required and generally not within 12 months of a previous plan. Ongoing management can be provided through the GP mental health treatment consultation and standard consultation items as required, and reviews of progress through the GP mental health care plan. So a rebate for preparation of a GP mental health care plan will not be paid within 12 months of a previous claim for the patient or for the same or another mental health treatment plan. So again, it's, you're setting these, it's not a set and forget, set these up, let's review it, but then they're not expecting it to be a new care plan within that 12-month period of time. So reviewing a GP mental health care plan, the review item is a key component for assessing and managing the patient's progress once the GP mental health care plan has been prepared, along with ongoing management through the GP mental health treatment consultation items. A patient's GP mental health care plan should be reviewed at least once. It's not a setup and then forget about it because you referred them off. You need to review, is this working? Has a patient attended? Are they okay? A rebate can be claimed once the GP who prepared the patient's care plan or another GP at the same practice has undertaken a systematic review of the patient's progress against the GP mental health treatment plan by completing the activities that must be included in the review. So again, lots and lots of words here, cut and paste, but you must review it. And then within that review, you must record the patient's agreement, review the patient's progress, modification of the document if required, checking, reinforcing and expanding education, a plan for crisis, and re-administration of the outcome measurement tool if it's required or if it's clinically appropriate. The recommended frequency for a review service allowing for variation in patients' needs is an initial review, which should occur between 4 weeks to 6 months after the completion of your care plan. And if required, a further review can occur 3 months after the first review. So they're looking for you to set up a GP mental health care plan and then review that plan within 4 weeks to 6 months. So it's not enough to set up a care plan and refer them off to psychology. You've done a care plan, how are they going? And maybe that needs another review after that. In general, most patients should not require more than 2 reviews in a 12-month period, with ongoing management through the GP mental health treatment consultation and standard consultations. A rebate will not be paid within 3 months of a previous claim for the same items or within 4 weeks following a claim for a mental health care plan. So rules and regulations, GP mental health treatment consultation. So these are the consultations that the patient doesn't have to have a care plan. So the GP mental health treatment consultation item is for an extended consultation with a patient where the primary treating problem is related to a mental disorder, including for a patient being managed under a GP mental health treatment plan. So you can do it under the mental health care plan, or it can be independent of that. A GP mental health treatment consultation, so this is a consultation, must include taking a history, providing treatment and advice, and documenting the outcomes of the consultation. The consultation must include taking a relevant history, providing treatment options, documenting the outcomes of the consultation. Consultations associated with this item must be at least 20 minutes long. So I know, I really appreciate there's so many questions and so much information around both the GP management plan, team care arrangement, and the mental health care plans. But given it's an hour and they're two quite meaty topics, it's just an overview of some of those item numbers. But I would really encourage you, strongly encourage you to go to mbsonline.gov.au for more information around those item numbers. And like we said earlier, it's your responsibility as a GP with a provider number to know what you're claiming. So some of the questions that always come up: can I claim a general consult MBS item at the same time as a mental health care plan? The answer is yes. If a GP mental health treatment item is undertaken or initiated during the course of a consultation for another purpose, the GP mental health care plan review or consultation item and the relevant item for the other consultation may both be claimed. Long story short, you can claim your 2713 and your item 23, or your 2715 if you've done the training and your item 23. So you can charge, bill Medicare for those two item numbers at the same time. It's with chronic disease management, you certainly can't, but with your mental health care plans, you can. So that's a yes. Can a nurse be a part of preparing a mental health treatment plan? This always comes up, this question. So all consultations conducted as part of a GP mental health treatment items must be rendered by a GP, a specialist mental health nurse, other allied health provider, practitioner, or Aboriginal health worker with appropriate mental health qualifications and training may provide general assistance to the GP. It's not saying that if you've got a nurse, a practice nurse with no mental health skills training, can they contribute to the mental health care plan? No. They need to have specific training around mental health. Can they contribute to a GP management plan for their chronic condition? Absolutely. But this is for the GP mental health care plan. Is there a set template I have to use? It is not mandatory to use any particular form when preparing and claiming for a GP mental health treatment plan, but it is mandatory to document the GP mental health treatment plan in a way which addresses the Medicare requirements. And that is exactly the same for a GP management plan for a chronic disease or like a care plan. It doesn't matter how that document looks or how it's been constructed, what's in it, as long as it has the Medicare criteria in there, you can add in all the other things that you like. So there is no one size fits all when it comes to templates for general practices. So I would strongly encourage you, if you've got some really great ideas around, mental health care plans or GP management plans for chronic disease, you can certainly, with Medicare's basic framework, with what they want, create your own and make it specific to your patient cohort. So we talked about outcome tools or measurement tools in a few slides. So which outcome measurement tool do I use? So the choice of outcome measurement tool to be used is at the clinical discretion of the practitioner. So some examples of outcome measurement tools include the K10, the short form health survey, or the health of the nation outcome scales. So you can easily look up those into Google and have a look. So there is no one set tool that you need to use, but it's up your clinical discretion which one that you want to use. And you may take into account your patient population, health literacy levels, ease of using the tool with your practitioners, with your patient population. So have a look and see, maybe you have them all in your library, in your document library, and you pull the one that's specific to the particular patient's needs, or as a clinic you decide on one. It's up to you. Bits to remember, and there is a question that's popped up, so I'll come back to that one. Chronic disease management and mental health treatment MBS items are intended for patients with complex care needs, but they come with rules and regulations, so you need to get familiar with them. Just my receptionist does it for me or my nurse does it for me, I don't need to know, is not going to cut it. You need to know what you're billing. But use your clinical judgment. It's your call. So as a GP, it's your call if the patient does or does not have a care plan. But again, there's a Medicare officer sitting opposite you. Can you convince them of your decision, and would a peer agree that that was a good call? If you have delivered a service, bill for the service. If you've done the work, bill for the work. I can't encourage that enough. And think big. Could a chronic disease management, like looking at your whole diabetes cohort, could that be a QI activity within your practice? And as a GP, you are legally responsible for the services billed to Medicare. I'm not saying that to scare you, but I'm saying it as an opportunity then to get to know Medicare. There's a question here: can a patient whose chronic condition is stable, mainly diabetes, have a new care plan every 2 years and review every 6 months? This is where patient understand their condition and they're capable of self-management. Yes, absolutely. As a business, if I put my business hat on, if Medicare says the recommended frequency is 2 yearly, then I'll bill it 2 yearly. And if nothing has changed, I'll just keep to it for 2 yearly and I'll review them every 6 months. If it gets to 2 yearly and I forgot that I could bill another 721, 723, and I keep going with my 732 times 2, that's okay too. Medicare will just keep paying review appointments for years. You don't have to do a new 721 to keep the care plan alive, so to speak. But again, it's your clinical decision. I've had clinics who have routinely done new care plans every 12 months because they'll say, well, we bill it and it gets paid. And it does get paid because Medicare is assuming that the patient requires a new care plan. There's been a new, there's a change in their health or a change in their disease state. I would say recommended 2 yearly with regular reviews, 4 to 6 monthly as you go along. And then having said that though, if you've got a diabetic patient who is on oral medications and then goes on to insulin, that's a significant change. It's a whole new lot of education and training and, just it's a whole other ball game for that patient. You could justify a new care plan at that time because their care needs are different. They've changed. They might be going back to the diabetes educator and know some more in-depth. But certainly if they're self-managing and they're doing okay, I'd do it at 2 yearly. But it does also raise an interesting question of someone saying, what about if on the care plan the patient's doing so well now that they no longer need a care plan? My thought is if a patient has diabetes, they should be on a care plan just for that regular review. And I used to explain it to patients. I'd be like, why do I have to go on a care plan for? I'm doing quite well myself. And I'd say, look, you are. You're doing a bang up job with your diabetes management. You know, you're doing so well. But what I want to do is better do this care plan so I can keep you in this system so that we're getting alerted every 6 months that you need your bloods checked, that you need your cholesterol checked, you know, that you need your foot checks and your eye checks and all of those things. It's a reminder for me to make sure that we're delivering the best care to you. So that's how I would sell it to those patients. Now, I would never take away from them that they're not doing a great job. Not, you know, they could be doing the best job, but it's so I can make sure that as a clinic, we're providing the best care for you. And that's how I would turn that around often. Hope that makes sense. So what's the time? Oh my gosh, we're right on time. So I know it's a lot of information there that we've gone through. I really appreciate that. I've do a lot of training around care plans and have spent a whole day on GP management plan and team care arrangement, a whole day. So I appreciate that it's a lot to go through in an hour. I'm more than happy if you've got questions. I'm happy to hang around and answer questions. I'm also happy if you want to email me at the email address there, admin@cdpd.com.au, and I'll happily answer those questions and I'll reply back to you. I can also CC in Beth from Rural Health West, who I know their organisation has lots of tools and resources to further assist practices in doing chronic disease management and health promotion. So I'll certainly, get them involved. They're just a wonderful organisation with lots of information. So any questions, feel free to email. If you don't have any questions tonight, but you go to sleep on it and you have a burning question, I'm happy if you shoot that through in a week, or if you forget the email address, ask Beth, and I'm sure she'll be more than happy to send through questions to me. But I think that's it from me. I'll hand it back over to Beth if you like.
Information on those topics. We'll so
I'm not sure if everyone's gone or if Beth can hear me. I was having trouble hearing Beth. Kept cutting out, so I'm not sure if that's a connection on my side or if Beth is okay.
yeah, sorry, Donna. I got that message that my last audio wasn't coming through very clear. I've just sent everybody a message. Yeah, so anyone who is still online, thank you once again for staying online. And as a reminder, I've recorded the session. I'll get it up onto our rural health